Okay, good evening, everyone. Welcome to this March meeting of the Health and Wellbeing Board. I think I certainly know everyone who's on the call, so I don't think we need to do introductions this evening. At this meeting, we are joined by a couple of people who have not been before, but I'm sure they can introduce themselves as we go through. Cornelia, do we have any apologies for absence?
Niha Unadkat? That's the lady who's given her apologies.
Great. Yeah, we can certainly note Neha's apologies. Fantastic. We don't have any urgent matters. Does anyone have any declarations of interest to make? No, fantastic. We don't have anything to be considered in private either, which means we can move on swiftly to the minutes of the January meeting. Does anyone have any comments on accuracy or omissions from those minutes? I'm seeing lots of shaking heads, so can I take those then as approved as an accurate record? And I'm seeing lots of nodding heads. Excellent, thank you very much. Which brings us on to the first substantive item, which is the Health Watch update. And we're joined tonight by Jamie Walsh. Jamie, I've lost you on my screen now. There you are. So Jamie, if you want to take us through the Health Watch updates, I think you've got two reports. There's a patient experience and the housebound report.
Lovely, that's right. So my name's Jamie Walsh. I'm the Director of Health Watch Operations for Your Voice in Health and Social Care. So I'm here tonight in Matt Hanmel Jones's place, who has moved on to pastures new. So I will share, you have the detailed full reports in your packs. I will share a summary version on my screen and talk through that. I don't think I'm able to share my screen. Is that...
Cornelia, could you make it so that Jamie can share her screen?
Okay, please try again. Please try again. I'm Jamie.
Lovely, that seems to be working.
Perfect.
Perfect. All right, lovely. So this is a summary of our quarterly patient experience report. So this is our Q3 report, where we heard 1,200 pieces of patient experience feedback from residents. 72% of that feedback was positive overall. And out of that 1,200, 524 were reviews received on GP surgeries, with smaller numbers there around hospital services, pharmacies, and dentists. So if we look first at the feedback around GP services, we've got 67% of people talked positively about their GP services, particularly in relation to the staff theme. And that is an increase in positive reviews of 8% from last quarter. So that's a kind of positive trend there. And in relation to staff attitude and customer service, we've got 68% of positive reviews there around that theme. And that continues an emerging trend from last quarter. So we're seeing some increases in positive feedback there around staffing, which is really good. In terms of administration, we had 43% of people being unsatisfied with the availability of appointments at their GP, with many talking about the lack of face-to-face appointments. We also had 42% of individuals providing negative feedback around that booking appointments, the actual process of booking appointments, with many, again, they're talking about the difficulties with telephone lines. In relation to treatment and care, this is where we generally see a lot more kind of positive feedback, and I see that's something for Ealing that we see in this quarter as well. So we have 88% of feedback around the quality of care being received, being very positive. And we have 79% of feedback around support, also very positive in nature. And 71% of feedback being positive around the general GP experience. Moving on to Ealing Hospital, again, around treatment and care, that's where we tend to see the greater positive feedback. So we've got smaller numbers overall, 92 comments compared to 500 odd for GPs, but out of those, we've got 74% of people very happy with the quality of care from Ealing Hospital. And we've got 65 of those talking about the support they received very positively. My colleague has highlighted here that that's potentially a trend to be monitored, which is more negative than it was the previous quarter. In relation to staff, we got 74% of feedback talking about staff at Ealing Hospital in a very positive light, and 76% happy with the customer service they received during their time in Ealing Hospital. In terms of other services, the report also talks about dentist services. We see a high percentage of positive feedback around dental services, and people particularly talking about the supportive nature of the staff and the efficiency of the treatment. And again, for pharmacy services, very positive kind of sentiment and feedback there around support from the staff and the efficient service. I think there were some negative reviews, isolated negative reviews, but they were present around not receiving medication and people experiencing that issue. For the COVID-19 vaccination and test centres, we had 69% of the reviews were positive in nature. Again, people, really talking about those helpful staff and that smooth service. There were some negative reviews or inconsistencies in the service delivery, perhaps in relation to the different vaccination sites or test centre sites, and an issue there highlighted around personal information being left unattended and that being noticed and picked up by patients there visiting those centres. So potential issue there to keep track of. So those are the main services we received feedback on during Q3, and some of the highlights there in terms of some of the steps that Healthwatch Ealing have taken or are taking. We have been adding additional sub-themes to our patient experience report to improve the detail of the Healthwatch Ealing findings, to really dig deep into some of those experiences. We have increased patient experience visits to Ealing Hospital to try and improve the intelligence that we can provide back to the trust. And some of that is around kind of getting back up to the numbers of feedback we had around Ealing Hospital before COVID. It was usually on par with GP levels of feedback. So it has significantly dropped. And we have been working with colleagues in Healthwatch Hounslow and Healthwatch Hammersmith and Fulham to produce a 2-year tri-borough analysis of GP patient experience information. That has recently been shared and I think was received very positively by Ealing colleagues, and shows the Ealing GP services in a very positive light when compared to Hounslow and Hammersmith and Fulham. So that's potentially another report that we can bring to the board or share more widely. In terms of some of our recommendations, those are again outlined in more detail in the full report, but just to summarise, around working with the trust to increase their communication around waiting times and using the Healthwatch intelligence information, comparing it with their own findings to kind of triangulate that data. It's about working with North West London CCG and the PCN leads to continue to support GP staff and further increase those positive areas of feedback, and working with Ealing Council and West London Trust to explore ways in which we can increase service feedback, particularly that's in relation to mental health services. And there's a lot of work going on around that across Ealing and Hounslow and Hammersmith and Fulham as well. And for Healthwatch Ealing as well, we want to continue to focus on collecting data from some of the areas of low representation, just to ensure we are assured that we're getting feedback from all the different communities and all the different kind of wards and areas of the borough. So that's a continued focus for us. So if you have any questions or feedback, I will stop the share of the screen.
Great, thank you, Jamie. So I think probably if we ask Chris, Simon, VJ first for any comments or thoughts kind of from the delivery side. I know there's probably a few things that we can pick up as well. Then we have had a couple of questions from the public that probably relate to some of the areas here. Chris, you've unmuted and come on camera. Does that mean you want to come in on the mental health one?
Only to acknowledge, thank you, with apologies for a slight late entry. With West London Trust, and also West London Trust as the lead provider of ECP, has been working with Jamie and her team to think about how we can improve opportunities for working with Healthwatch to get patient feedback. And we've been exploring some ideas for using the Enter and View powers to some of the mental health transformation work, particularly in Ealing.
Great, thank you. Simon.
Yeah, couple of things from me. Firstly, thank you very much for the report. Very helpful to see it and the feedback. And you mentioned a bit around increasing the sort of patient experience feedback and the visits to the hospital. If there's, so obviously because of the COVID and Omicron variant, that probably has impacted upon it. But if there's anything I could do or the hospital needs to do to help facilitate those visits, more than happy to do that, and also to link up with our own sort of, I think you talked about linking up with our own sort of patient experience sort of feedback and the lead across the trust, and very happy to help facilitate that as well. And then in terms of waiting times, so we are, key focus for us now is around elective recovery, diagnostics recovery, outpatients, and we have significantly improved where we've got to on that front. I've got a couple of slides later on that I may or may not get a chance to talk to, but we have opened up a lot more of our elective capacity going forward. We're now up to sort of 93% of MRIs, ultrasounds 60%, endoscopy 73%, echoes 124%, and our electives now is back up to nearly 80% of what we were doing pre-COVID, and our outpatients are up to 96%. Having said that, there is some backlogs in the system, and what I'll try and do is we'll try and at least put on our sort of website more detail around waiting lists for particular specialties or services going forward. So thanks for the feedback.
Great, thanks, Simon. And Vijay, I don't know if you want to say anything about the GP aspect.
Yeah, sure. First of all, thanks, Jamie, for that useful summary. That's really helpful. The area I want to pick up on mainly is around telephone access, and we've known for some time that the patient experience around telephone access has been suboptimal across not just Ealing but across every practice across Northwest London. And we have now secured a significant amount of funding to go into GP practices to improve their telephony system from an analog system to a cloud-based system going forward, which will allow practices to do a number of functions which will improve patient access over the phone. One of them is around having much more clear options within the telephone system when a patient rings, in terms of which individual they require the assistance of. So having some more robust options. But I think more importantly, the cloud-based technology will allow practices to analyze the call volume and traffic of calls coming into GP surgeries, so that they can then bespoke the number of staff answering the calls depending on the time of day to manage that demand. But also it will allow practice to understand the number of calls which have either been abandoned or been dropped for one reason or the other. So really it will just give the practices that information for them to then configure their workforce and also organize how they manage that access. So this investment is going to come into practices very shortly, and practice will be engaging with a select number of providers which have passed the compliance issues around telephony for primary care. And so we will see in the future, well, our expectation is that we'll see an improvement in the experience of telephone access in general practice across Northwest London.
Great, thanks, Vijay. So did anyone else have any comments or questions, either to Jamie or to kind of picking up any of the points that are highlighted in that report? Fabio.
Thanks. It was just on the, so when you go through the report, I think you mentioned in your summary there's 554 GP surveys that happened, but I wasn't sure, because when you flick through sort of by GP practice, that obviously I haven't had it all up in my head, but they're tiny numbers, like one per practice, 4 per practice. The most had something like 26. So I wasn't sure where, does that all add up to 560? I couldn't really see how that could. I just wondered where all those 560 surveys are. And there's lots of practices that have either 1 or 0 survey responses. When you go through, I think it's all sort of in the page 41 onwards, but it's broken down by practice. So I was just wondering, is that practices that just aren't engaging to want to be like to get involved with having their patient surveyed? What are the reasons? There's quite a number of practices that have absolutely no responses at all.
So thank you. That's a really helpful question. In relation to the 500 odd number, I mean, it should add up, so we'll check that. But there is also a difference that is helpful to explain around the number of reviews received versus the number of theme counts. So for example, one person can leave a review, and when you look through the content of that can highlight, say, 5 different themes. So that one review then counts as 5 themes. So the numbers do change there depending on which bit you're looking at. So that might explain what you're looking at. In relation to the low numbers of feedback from some practices, that is something that we we look to each quarter, and over the course of the year we try and ensure that each practice has been visited and that those numbers collectively over the course of the year are obviously bigger. Quarter to quarter, that is a challenge, and it is a particular challenge in Ealing because of the 70 odd practices. We look at Hounslow, you're already down to 45 practices, and Hammersmith and Fulham, I think it's 29. So it just represents a kind of logistical challenge to get our teams and our volunteers to every single practice in the borough each quarter. So that is why you see some of that. And another contributing factor is that we have this internal target around receiving 1,200 pieces of feedback, and visiting some of the very small practices means sometimes we can only talk to 1 or 2 people in the waiting area, and some of the larger practices represent higher volume for us, and we get feedback from them on the practice, but also on their hospital experience, on any other experience of health and social care that they may have or have the time to share with us. So all of those kind of factors play a role, but certainly over the course of the year, we try and ensure that we have multiple visits to some of those smaller practices to try and up those numbers a bit, but it is an issue.
And I wonder, Jamie, just on that point, and thinking about perhaps the Race Equality Commission item that we'll be talking to later, whether actually if you do struggle to get around with the team that you've got, whether some of that resource can be focused more in areas where we think it might make more of a difference, and kind of focusing on particular communities and therefore kind of how their experience of healthcare might be different from other parts of the borough. And maybe that, if there is a resource issue, maybe that's the way to kind of focus it. I don't know.
Yeah, that's certainly something we have been looking into or have done in the past, is focus on, let's say, the wards of highest deprivation and all the practices in those wards. So that's certainly something we can talk about outside this meeting, about any particular areas you'd wish us to target. Very open to that.
Great, thank you. So any other comments or questions on the patient experience report? Vijay?
Yeah, just really a question for Jamie. I know that during the COVID pandemic, the majority of the responses were remote, online responses, questionnaires, remote responses, and again that then potentially pre-selects some of the feedback that you get. And clearly now that Healthwatch are now have now got the ability to actually come into practices, I think you probably will start to see a change in the feedback and the quality of the feedback as your staff start to go into practices more and to really ask the questions face to face with the individuals actually in the practice. I think that will make a difference going forward.
Yeah, thanks, Vijay. We are very much back in practices in Ealing, where we are being welcomed, and we have seen that change and a kind of increase, and kind of some of those themes and trends that we used to see previously. There was a bit more negativity because of the sourcing of comments prior and the lack of being able to reach people on a face-to-face basis. So we continue to monitor that and see how that translates as we transition more and more back into services. But yeah, that's helpful. Thank you.
Great, thanks. And then just before you move on to the housebound survey, slightly less for you and more for Kerry. Roy had a question based on the experience reports and how we get feedback from people. A question on social care experience within Ealing and how we get reviews of council services. Roy, did you want to ask that yourself now, and then Kerry can give a response?
Yes, if I could just make a comment and then and a question, really. Just to say that obviously Healthwatch mainly covers health and medical services, as far as we can see in terms of the reports that are presented to the panel. And we'd like to see more surveys and reports on the social care experience within Ealing. And really, it's a question of how the board helps Healthwatch to increase the number of reviews of council-led services. I'm glad to see that mental health is going to be covered. Obviously, that's important as well. But obviously, more data and service user and family carer experience of day residential and domiciliary services would be very valuable from our point of view. Thanks.
Kerry, sorry, Jamie, happy for you to pick that up, but I do feel free to use Kerry as well.
Can I respond briefly? I'm sure Kerry will
Sure.
chip in. I think you're right, Roy. It's another area that has kind of, I guess, traditionally been a challenge, and because we can, we physically can go out to the hospital and GP practices, that has been the mainstay of the patient experience program. That's not to say we cannot expand and try different routes and techniques to increase the social care feedback, and we very much value that partnership working to find ways to do that, not least obviously visiting some of the sites that you mentioned. But what we do try and do in Healthwatch is balance that health and social care across our whole service provision. So you'll see I'm just about to present this housebound report as well. And so whereas we could argue that the patient experience program may focus more on health services, we use our research studies and our interim view programs to very much pick up the social care side. So we try and find balance within the overall. I appreciate the comment and the question and the challenge. And I think there's definitely more room for us to scope out opportunities in the patient experience program as well to get the social care comments feeding in and at much higher numbers that we can do that trends analysis in the same way each quarter.
You've stolen my segue into your next item already, but before we do that, then Kerry, did you want to say something about how we gather data and feedback?
Yeah, thank you. So, and just to agree with Jamie's points, we've worked closely with Healthwatch over the last couple of years, and certainly in the last 12 months, Healthwatch have completed 2 significant surveys of people's experience of services during the pandemic. And we're going to hear the housebound report shortly, and also the wider report in terms of people with disabilities experience during the pandemic. We've also worked closely with Healthwatch with regard to the Enter and View programme, which we think is a really useful independent view and position given in terms of services. And Healthwatch has done lots of work with us recently around Colette House and the mental health hostels within the borough following the tragic death of Jenny Foote and the subsequent investigation. Happy to take forward your suggestions, Roy, in terms of discussions with Jamie. We can look at using the statutory returns and surveys that we have to complete within the council through the ASCOF programme, and that's something that we can certainly look at discussing in the future plan for 22-23 with Healthwatch.
Okay, thanks, Kerry. So, Jamie, do you want to then take us through the housebound report?
Yes, so I'm going to share my screen again for a summary version. Can you see that? Perfect. So this is a summary of some of the findings from our housebound survey that we carried out in 2021, working very closely with Kerry and colleagues to enable us to do this. So we were able to speak to and hear from 192 completely or partially housebound individuals, talking to them about their experience of services, home care services, but other services related to receiving them in the home during the course of the pandemic. So in terms of access to social care, we had 52% of respondents reporting that the support they got from Ealing Council was either good or excellent. We had 43% of respondents identifying that they did receive the required adaptations and equipment from Ealing Council during the pandemic. Around access to information, 60% were aware of all the ways that they could contact their home provider during the period. But 72% did have difficulties in accessing just general kind of information during the course of the pandemic. For social care staff, 46% of respondents indicated that their carers were able to complete tasks to a high standard, and 64% rated their carers' attitude and behaviour as good or excellent. We had 37% identifying a language barrier between themselves and their carers, and 52% identifying that interaction they had with their carers during the period really helped prevent them from feeling lonely and socially isolated. So that, that value from human contact at what was quite an extreme time. 73% of individuals felt that their carers were very attentive and provided, their individual needs and preferred ways of doing things, were able to deliver that during the course of the pandemic. Around digital access to care, 70% of individuals believe that the reliance on digital technology during that period did affect their ability to access health and care or services, or address their health and care needs. But only 40% felt that reliance on digital technology impacted their information about home care support. So that was obviously a sector. When they had that direct service, it worked a bit better getting access. Around access to healthcare, we had kind of feedback on district community nursing services receiving the highest number of positive responses. And GP home visit service receiving the highest number of negative responses around that service during the pandemic. And in relation to pharmacy services, 87% of people identified that they were able to get their prescribed medicine during that period when they needed it. Around COVID-19 and vaccinations, 82% were happy or very happy about all the information they got around booking appointments. 80 booking appointments for the vaccination. 80% were happy or very happy with all the information they got around vaccine safety. But 35% were unhappy or very unhappy about the information available around side effects of the vaccine. So those are the kind of core areas and some of the findings that the study drew out from the responses we received. So the full report identifies quite a long set of recommendations. I think there's around 20 or so. This kind of encapsulates the majority of those. So we have recommendations around ensuring that all housebound individuals get that comprehensive social care assessment, that there is a review around mandatory training and development to ensure that all the carers and the substitute carers can deliver care to the same high standard. There's a recommendation around combining the training and supervision to use that opportunity to address some of those inconsistencies in quality of care. We want to make sure that communication between care providers and carers and housebound individuals is improved, and there's some suggestions around that. And provide clear instructions on how they can access information and care, including a kind of clear designated point of access for people. To exercise an integrative person-centered approach that accounts for the very best methods of health and social care access for people. We recommend around conducting an annual survey of social care service user experiences, and look to statutory partners to work with community organisations to help provide that kind of supplementary support. So that might be around mental health wellbeing or access to those digital devices and skills training that will already be taking place in some places. So as I say, those are the summary of the recommendations, but I think the report outlines 20 or so. And Kerry may want to jump in here, but obviously the council have been working on a response to those recommendations and an action plan. And we will continue to work very closely with the council on this report and our disabilities report, which there is also an action plan for already in existence. So I hope that's given you a bit of a whistle-stop tour, but if there are any questions or other feedback, or indeed, Kerry, if you wanted to jump in there.
Thanks, Jamie. That's really helpful and really good presentation of the data as well. I think that the infographic, rather than just rely on the quite lengthy report, is really helpful. So thank you for taking us through that. Kerry, did you want to just respond then from our side, and then we can take any other questions and comments?
Certainly, and just to thank Jamie and the Healthwatch colleagues for this report, which did build on the wider disabilities report that was received towards the end of last year. We're developing a integrated work plan that will take these lessons forward from the reports and implement actions around the recommendations. I think it's worth noting that this was an extraordinarily challenging time for people who use services, but also service providers during the period when the survey was completed. But there are lots of lessons here that we need to take forward. I think there's commentary within the report with regard to the reliance on digital channels of reaching people, and I think that's a real lesson that we've taken over the last 2 years, in terms of you can't channel shift everything into the internet and electronically for our customer base, and that's something that we're working closely with the partners within the community as a whole to resolve. But what I'd propose, Chair, is that we bring a action plan back to this meeting. This report's also been to the HASP, where we're being scrutinised in terms of the work plan. So I'd propose we bring it to the HASP and then to here.
Yeah, that sounds like a really good idea, Kerry. And then we can monitor progress on the various actions, which I think also covers Roy from Skag's question about action reports go and where they will go. So I think we can cover that. Does anyone have any comments, questions then on the report? Judith?
Yeah, just to add with Kerry, we very much appreciate Jamie's work in producing this. I think it's a really helpful position for us to build from. We can see that our customers are telling us that they want better services from us, both starting from the assessment and working our way through. So there's lots for us to get hold of. And as Kerry says, we're building that action plan. It's really, really important feedback, and we'll entirely accept that. And then see the annual survey in a year's time. We expect to see also to be able to demonstrate that progress. So I think that's a really helpful piece of work. Thank you.
Great, thanks, Judith. VJ? You are muted, VJ.
Here we go. Start again. Thanks for that, Jamie. Again, it's a really useful summary. There's a couple of areas I just wanted to pick up that you brought our attention to. One was around the GP home visit and the level of dissatisfaction. I think what one needs to be mindful, especially in a COVID pandemic, that the request for home visit, the paramount criteria is clinical need rather than expectation from the patient, and so individual clinicians and practices would have carried out a clinical triage to assess whether a home visit was required, or whether that clinical assessment could be safely done remotely. And I guess that sometimes does lead to misalignment and dissatisfaction in patient experience. So I can understand why potentially that percentage was low. The other one was around the side effect information from the COVID vaccine, and I think this one again has been somewhat challenging, because clearly there's a lot of unknowns about the COVID vaccination and how individual patients would respond to it, and clearly it would be difficult for any clinician to be able to describe to the patient what are all the potential adverse effects and side effects of the COVID vaccination, because we were continuing learning in terms of how individuals responded to the vaccination, and that's balanced to the priority was to try and get as many people vaccinated in a short period of time, and so clearly the housebounds were a particular vulnerable group, and we had to utilize the workforce to be as efficient as possible to ensure that they were managed to get through all the housebounds right across Ealing, and they may not have been able to spend 20 or 50 or 20 minutes or longer with an individual who explained all the ins and outs of the vaccine during that time. So again, we just need to have a balanced opinion in terms of some of those percentages in the report.
Great, thanks. And I think there was a question just posted in the chat from Maggie about the kind of the coverage of how accurate, I suppose, the notes are on patient records. So that, do GPs know that every housebound patient is housebound, for instance, and therefore, is that part of the problem?
I think that's work in progress, because GP practices in terms of record keeping are better than they used to be in terms of coding housebound patients. They have a much better idea in terms of the number of patients on their register list who are housebound. It's better than it was, in the past. It was somewhat unknown, but I think we're definitely in a better position now in terms of having a much better idea of those housebound individuals in terms of making sure that the services and care are focused to those needs.
Great. Jamie.
Yeah, thank you. And I just wanted to pick up on the vaccine kind of side effects issue, Vijay. I think it's a really interesting point, isn't it? But I think given the national coverage and the changing picture throughout the period, it was obviously very difficult and challenging for people on the ground to process that information and make the decision they needed to make. But I think, it's potentially something to think about in terms of other vaccinations and childhood vaccinations and some of the other immunization rates we have in Ealing. And if this issue about side effects is, cropped up in one area, it's likely to be a factor in some of the other vaccines. And maybe it's just about thinking about that and providing information to people about clear and very transparent information to people about the side effects of some of those very common, vaccines that we still have issues around uptake from. So yeah, just some potential learning, I guess, to take across into other areas.
Yeah, absolutely. And I think that unless there are any other kind of questions or comments now, it probably gives us a good kind of place to move on to the public health section of the agenda. And I'm sure Anna will talk about some of that, exactly that kind of lessons learned, Jamie, in terms of moving forward and the public health report and vaccination campaigns. So Jamie, thank you for those. Those are really helpful reports, and it gives us some work to do as well, which is kind of probably better than just coming here and us talking about it. If we go away with something to do as well, it makes it more worthwhile. So thank you very much. And Kerry's now got a lot of work to do in the next year to get these surveys up and running and show progress. So thank you very much, Jamie. So Anna and Helen, do you want to take us through the living safely and fairly with COVID item?
Yeah, will do. Thank you, Chair. Evening, everybody. So my name's Anna Bryden. I'm Director of Public Health at the Council. And in a minute, I'll hand over to Helen Castledine, who's our consultant in public health, who leads on the COVID response. I think Jack from Democratic Services is going to share our slides. Jack, if you can do that. It's just coming up. So while that's loading, I'll just kick off. So we just wanted a not our usual COVID item here, but just a little bit of a forward scan of what this next phase looks like. Just wanted to give a little bit of a kind of overall public health perspective, I guess, on what that phase is looking like and what we across our partners are going to be focusing on. So I think just I suppose 3 points from me. First is there's very much less of a universal offer going forward in terms of kind of national government guidelines and what's going to be on offer, especially in terms of testing. I think importantly for me, there's definitely continued support and work going on in terms of safer behaviours, communities looking out for each other, etc. So a lot of that communications and engagement that we've seen isn't going to just stop on the 31st of March. That really will continue for as long as it's useful. And then thirdly, for me, I think that very much a continued focus on inequalities and working in partnership with our communities, especially around vaccine equity. I think that work will really really push forward in the next few months and hopefully morph into something really strong using those lessons learned from COVID on lots of different topic areas as well. So I'll just hand over to Helen, who's just going to take us through the brief slides on the what's been happening in the next steps. Thank you.
Thank you, Anna. Jack, could you move to the next slide, please?
Apologies. There seems to be a
Is it frozen?
Yeah,
apologies.
don't worry,
I should be able to fix this in a second.
That's all right. I was going to suggest, Helen, maybe just start because those first couple of slides are quite straightforward anyway.
Yeah, so the first slide when it appears is just about the government's overarching approach to COVID, which I think we're familiar with now, which is obviously a rollback and a decent basically taking out the testing provision, taking out the which will be effective from 31st of March. Oh, is it coming back again now? Hang on 2 seconds. So. Okay, so these are the general principles that the government is working to now. So that living with COVID. So as I said, taking away the restrictions. Just kind of relying on common sense, basically looking at to kind of encouraging safe behaviour, looking at those long-standing ways that we've had of managing most respiratory illnesses. So going back to the kind of principles that we've had in place when people have had other illnesses such as flu, that kind of idea of not going out and spreading it to people and kind of staying at home, keeping yourself well and keeping your family well, but also keeping the rest of the community well. And this idea of protecting people who are most vulnerable to COVID-19. So the continued focus on vaccination. So we are continuing to offer vaccination, and there is targeted testing as well. Obviously and then just maintaining that resilience. So remembering that hasn't gone completely away, so kind of having that ongoing surveillance, keeping an eye on the numbers, having some contingency planning, so if numbers, if the numbers do go up and we are facing outbreaks again, that we do have some plans in place to manage that, and that ability to kind of introduce key capacities such as mass vaccination and testing in an emergency. And then looking at the innovations and the opportunities that we found from the COVID-19 response, so those innovations around the mass vaccination, things that we've talked about for years around doing for flu, looking to kind of use those models, those hyper-local approaches, and moving into that, and then investing in the life sciences, so investing in the research, looking at the different things that we've learned. So things like today, there was something about continuing the wastewater surveillance, so learning about that, looking at how we can use that to have surveillance of other communicable diseases. Could you move to the next slide, please, Jo? And then I just wanted to outline just very succinctly the key changes, which I think we're all familiar with, that there is now no legal requirement to self-isolate following a positive test, but you are advised to stay at home and avoid contact with other people. And that differential there was between the fully vaccinated and the vaccinated, so the close contacts are not legally obliged either to stay at home if they're not fully vaccinated. And then there is this particular nuance that there is different guidance around testing and self-isolating for people in vulnerable services such as adult social care, healthcare, and prisons and places of detention. And then on the 24th of March, statutory sick pay and employment and support allowance relating to COVID will end. Could we go to the next slide? So these are our next steps. So on the 1st of April, there will no longer be this universal symptomatic and asymptomatic testing for the general public in England. So that means that our testing sites will be closing and they won't be accessible to the public. But there will be some limited symptomatic testing available for small numbers of at-risk groups, and the government is currently working on sending out the details of that and quantifying which groups will actually be eligible. But I know there's been lots of discussions about some of the vulnerable groups, and I think somebody raised previously at another meeting around vulnerable people who are housebound and have people coming into the house, and they have been included in the scope. So we're hopeful that there will be something there to support them, and we can, if not, we can look at something locally. And social care staff will still have this ability to undertake free symptomatic testing. And then we'll continue to support vulnerable residents, whether that is through support through our services or it's providing information and looking if there are needs around testing, how we can best support those. And then one of the big programs that we're doing at the moment, which we received substantial funding for, is the Community Vaccine Champions Programme. We've been working on this now since January, and we've got funding through to July, which we're stretching out a bit to September because we've had some delays with recruiting staff onto the programme. So we're hopeful we can run it across that whole summer period as well. And this is very much building on that strong community response that we've seen throughout COVID, looking at that asset-based response, looking at the strengths within the community, and engaging with them and working alongside them and collaborating with them. So we're not kind of putting things in there, we're working with them, asking them what works. And we're very much taking a holistic approach, rooting it in health and addressing health inequalities. So not just addressing some of the misinformation about vaccines, promoting vaccine uptake, but looking at how we can kind of promote that as a wider holistic health offer, making the links into some of the other services. So looking at how we can talk to people about management, blood pressure, and we've already had quite a lot of innovative events that we've had in progress across the borough, which has been received very positively by residents, and we're now looking at shoring those up and putting pathways in. In terms of the programme, we've started to scope our kind of hard to reach communities. So we've particularly identified traveller communities as a group that we haven't engaged with over COVID-19. We know obviously they experience poorer health outcomes than other groups in the borough. So we're looking to build that work, bring a community partner into our each consortium, and to look at how we can build that trust and relationship with that group. And obviously recognising that we do have significant, though small, Ukrainian population that's likely to increase. So also working with them as well to tackle health inequalities and to offer them the access to the vaccine. And then the other piece of work that we're working on, which you'll hear more about later in the equality and the race equality update, is the lessons learned. So what can we learn from the response? What's gone well? What's not gone so well? If we were going to do it again, what would we do? To make sure that our response was more robust? How can we make sure that we don't lose that learning, but also the relationships that we've built up with the community? So the relationships we've built up with the community pharmacists are really strong. They've been very committed to the community testing programme. How can we use that enthusiasm and commitment to address and harness it into our future programmes? If you can go to the next slide, I think this is our last slide. So this is around living safely with COVID. So we're still encouraging people to take steps. COVID hasn't gone away. It's still out there. So there is still a benefit from getting vaccinated. And if you're meeting indoors, letting fresh air in, and if not,
I think we may have lost Helen. Anna, do you want to just pick up this last little bit?
Yeah, will do. So yeah, just the usual messages. So carrying on wearing a face covering where it's kind of crowded and indoors. The getting tested is up until the end of March universally, but those testing sites are still there. You can still get PCRs if you're unwell. LFT offer is still there, and obviously if you are testing positive through any sort of testing at home. I think one of the big changes, especially going in after April, is this national guidance around staying at home if you're feeling unwell. And I think we are expecting further guidance on what that means, because if it's not COVID, it'll be flu or colds or something else that can be passed on, helping protect each other, especially those more vulnerable. So that includes workplaces, things like that. Carrying on with social distance for now and regular hand washing. So I think that's the end of those slides, Chair, but very happy to take any questions.
Great, thank you. Are there any, everything moves around. Any comments or questions on that? I think it's mostly self-explanatory. Where we have guidance, we have it, and there's a number of areas where we are still waiting for guidance, and hopefully it will arrive before the 1st of April. Although, given how quickly they pulled the plug on the contact tracing with very little notice, I'm not holding my breath that we get that before the 1st of April. But there we go. That's how local government has been treated in the last 2 years, despite propping up the COVID response at every twist and turn. Any comments on that then, or shall we move on to Anna? And now my agenda has disappeared. The annual public health report / health and wellbeing strategy.
Yeah, will do. Jack, if you're able to share screen again, that would be great. Thank you, Jack. So just to introduce this, this board has seen a lot of this work over time in bits and pieces. So I'm going to run through it relatively quickly, but just wanted to update you on where we're at and the next steps. That's just loading up.
Can everyone see that?
Yeah, that's come up, Jack. If you can go on to the next slide. Sorry, I can start talking while you're fixing it. Don't worry, Jack. Let me just load up mine.
Same problem.
That's okay. Let me just load up mine here, and I can talk off it at least for now. I think I'll
That should be it now.
Oh, there we go. Thanks very much. Great. So wanted to just talk very much about the health and wellbeing strategy, but the public health report will be influencing it. So health and wellbeing strategy is one of the statutory responsibilities for the board, carried out every few years. The last one was done in 2016. Obviously, our work on the next one has been delayed by a year or 18 months due to all the COVID work. Since that last strategy was published, obviously a lot's changed, COVID being one of those, and we are looking at the new strategy in that context. The 2016 priorities are shown at the bottom there. They're all still relevant, and as part of the work to develop the new strategy, we will do a bit of a look back to see how as a system we have done with those priorities and what's left. Next one, please, Jack. Thank you. So just in terms of context for developing the Next Health and Wellbeing strategy, obviously we've had the COVID impacts have been very unequal. So we have seen an awful lot of our residents and communities affected much more harshly, and both in terms of direct and indirect impacts from the pandemic and over quite a long period of time now. Over the last year to 18 months, we have been carrying out what we call this impact assessment for COVID, which I'll touch on in a minute. That's really been looking at all those different impacts that communities have felt, and not just looking at kind of single impacts, but actually one on top of the other. How has that been for our communities? How have they been affected? We've written that up as our annual public health report, which is just about to be published. We have had cabinet member approval for this. We're just waiting for the call-in period to end, so that should be published sometime next week. And obviously, when it is, we can circulate the link round to this board. We've, as part of that work, when we were looking at those impacts, a lot of our partners developed essentially a system-wide principles and ways of working to help reduce inequalities and address those root causes. So very much with a kind of long-term view about how we can carry on tackling inequalities and doing better at that. At the same time as this was happening, we've obviously had the Race Equality Commission report, which we'll touch on in a minute. Lots of other sources of information coming through council, NHS, etc. And all of that will help develop the health and wellbeing strategy going forward. Next slide, please. So just we have come here before with some of the findings from the COVID impact assessment and some of the community feedback, but just wanted to touch on a couple of key things here because it's been quite a while now. These are just some of the quotes we found from our resident community feedback. I think a couple of important things are about people feeling that some of the gains that the borough had before the pandemic on different health issues might have been lost or need to be kind of started again. A lot of discussions about the kind of underlying cause of inequalities here. I think we saw a lot of that with the pandemic, especially in terms of, say, frontline workers, etc. And similar to the Race Equality Commission, you know, some very clear statements about institutional racism and similar issues. Next slide, please. So just very briefly as a summary on the impact of COVID, when we're talking about direct impacts, so that's actually being ill at the time, potentially developing longer term COVID symptoms, impacts on mental well-being, people ending up in hospital or unfortunately dying, and some of the very quick impacts seen in terms of if self-isolating, not being able to work, issues with employment debt, etc. And then a massive range of indirect impacts, and obviously these link into each other. So increased use of alcohol, less physical activity, including for older people not getting out and about more and losing their strength. A lot of issues around management of long-term conditions and how that was affected over the pandemic, and then really, broad, real impacts in terms of employment issues. The educational attainment gap between children in kind of most and least deprived groups really widening. We've seen that with childhood obesity as well, that gap widening, and just lots of lost opportunities. The next one. Thanks, Jack. And I think just really importantly from some of the things we were finding, a lot of, I was saying a lot of these risk factors and impacts were kind of on top of each other. People who, men were more likely to have COVID and end up in hospital, older men, people who were in frontline occupations, people from certain ethnic groups, especially Black and Asian ethnic groups, people who are living in multi-generational households, and if you add all those all those risk factors together, that obviously multiplies. And I think in here especially people with diabetes particularly, and other long-term conditions were more likely to be the people that were unfortunately in hospital or died due to COVID. And we were seeing that kind of very geographically within our borough, where we had high rates of diabetes and higher South Asian populations, for example. Next slide. Thanks, Jack. So I'm going to just run through this next section quite briefly. There's a lot of detail in here, and I think as we're developing the health and wellbeing strategy, there'll be a chance to have some in-depth discussions here. There's 2 slides here that summarise these principles for how we work across our local partners to help reduce inequalities and really tackle those root causes. So, for example, we've got here structural racism, digital exclusion, we've talked about here before at the board. One of these I just wanted to pull out was about this whole systems approach and the kind of thing that means. If we can move on to the next one, Jack, please. So we've just put in a very, there's a lot of detail here, apologies, but we've just put in a little example here from Greater Manchester. We're not recommending this as an approach, but it's just a really good example of that whole systems approach. So really focusing on mental well-being, going out and having those conversations with local people, and using that to inform planning for how we do mental health recovery during and after the pandemic. So next one, please. So, next one again, thank you. Thanks, Jack. So just running through the kind of second half of these, there's a lot of, when we talk about hyperlocal, what we mean is essentially just very small community areas. So an area around a small town centre or GP practice, etc. And I think we're really showing that with a lot of the community engagement work and the inequalities through the COVID pandemic. I just wanted to pick out anchor institutions towards the bottom as an example. So anchor institution, for those that haven't come across the term before, are organisations, institutions that will always be in an area, so or that are there with long-term relationships. So, for example, the council, a GP practice, local pharmacies, local hospital, big employers, etc. So, really trying to kind of lever that influence in the local area. If we just move on to the next slide, please. So just again, just an example here where that's been done somewhere else in quite a big way. So you might have heard of the Wigan Deal. This was essentially a big programme of work for between the council and residents to have a kind of deal with each other about how they work together for their local community, prioritising kind of building up that community wealth and using those anchor institutions as being quite a big part of this. So, for example, having local apprenticeships, commissioning services where you can from local areas. So, for example, if you're doing catering, that kind of thing, and really helping to support local people in upskilling so that they can get jobs either in that area or elsewhere. So next one, please, Jack. Thank you. So just to finish off, we just wanted to put down, as we're developing the strategy, there's a lot of work to do. It's going to be a very broad strategy, and I think I'm really keen that we end up making it as meaningful as possible and really coming out with some I suppose promises to each other across our partnership of how we do this, but I think also very, very importantly in collaboration and having those two-way conversations with our local residents and our local community groups, and the local organisations and businesses that are out there in the borough. So the engagement, we're going to carry on, we're going to do this work essentially from May up until the other end of the summer. That will include some health and wellbeing board workshops, for example, just to get this going and have those detailed conversations. But we're also hoping to do a really, really broad consultation on this, and hopefully ask some of our community leaders to actually lead some of this consultation, so in-person focus groups, some online things, actually using a lot of the engagement we've done already through other routes as well. You'll see the big list on there. And I think just importantly that this board obviously owns that strategy and will be taking it forward. And I think that will obviously be here for approval, but also then really importantly, how do we actually take it forward? It's a 5-year strategy, lots to do in there, and really thinking about that when we're talking about the work programme. Next one, please. Thank you. So just a couple of questions in terms of the board, if anybody does want to input at this point in terms of whether that proposed approach fits with what you're looking for. Are there any sources of insight? Are there any particular people, organisations that we really want in here, and any key groups to include in the engagement activity? Any suggestions? That's all. Thank you, Chair. Thanks, Jack.
Brilliant. Thanks, Anna. So this is really the item that gets the board back on track for after the COVID hiatus. So it's a really good piece of work, Anna. Thank you for pulling that together. So I think those 4 questions, which we've now lost, but I don't know if someone can pop in the chat for us, are key. So I think really we're looking this evening for approval for that being the approach, Anna. Is that what we're, yeah?
Yeah, I think that's the main thing. Just any thoughts on the approach and anything, any key suggestions for going forward? Great.
Simon, you've unmuted.
I have indeed. Yeah, thanks. So thanks, Anna. Really helped this set of slides. Two things from me. When I speak later about the trust, we're about to embark upon a review of our strategy at the same time, running alongside of this. And part of that will be about reaching out and engaging. So there's an opportunity for us to do some of that in tandem, really. But the second thing is, you mentioned a bit around the anchor organisation, and again, I think, as part of our ambition, as well as the social value in procurement, and I know that our procurement team have been speaking with Ealing Council, but it strikes me there is a real opportunity. We try to join up what the council's trying to do, what we in health are trying to do, and I'd include West London on that front. We probably ought to get some key people from each of the organisations and a steering group looking at that, because I think we ought to be able to leverage some health and wellbeing initiatives and support coming out of that through the social value procurement, but also things to we've been notoriously bad at accessing the apprenticeship levy and the training and development and opportunity things, and looking at some of the things around employment. There must be some great opportunities for us, I think, going forward, but it probably needs some senior sort of leadership, sort of brainstorming type session in terms of how we join that up in terms of what does good look like for Ealing collectively.
Thanks, Simon. I think that's precisely the approach, and yeah, I think, Anna, the workshops will kick that off, those discussions.
Yeah. Thank you, Simon. Yeah, I think we'll do a couple of kind of all health and wellbeing board workshops, but underneath that, I think there'll be some specific work streams. I think anchor institutions is a great one, workplace health, things like that. I think for me, agree with Simon. Some of this is about consistency and us as a partnership agreeing between us all what's important and how we do it together. And really showing that partnership across our residents. Thanks.
Thanks, Judith.
Yeah, thank you, Anna. That was a really helpful presentation. I'm very happy to be involved in the work going forward, and appreciate Simon's desire to make this more than just a health-based programme, that it's very much touching on the economics of people's well-being, which is absolutely critical to make the most difference, and kind of sits under the sponsorship, therefore, of the LSP as well as the Health and Wellbeing Board. But we can take that forward and think about it. The voice of young people is getting quite well developed in this borough, Anna, so it's worth looping them into this as part of that participation and engagement strategy. But yeah, good work. Thank you.
Okay, and Chris.
Thank you. I also wanted to endorse strongly the work and the approach, and to echo Simon's comment about joint working around anchor institution work. I guess wearing not a trust hat, but an Ealing ICP hat, also to reflect the fact that the outputs of some of this should really be informative regarding the work plan for the ICP going forwards for all of us as health and care partners.
Yeah, Anna, I don't know if you want to.
Yeah, I agree. I think with those policy changes where we've now got an integrated care partnership and a health and wellbeing, but I think that's how I see it, is that the health and wellbeing strategy really helps drive the delivery work through the integrated care partnership, and a lot of the key partners are sat around those tables and can do that detailed work. So I think that's great. And just very briefly, just going back to what Judith was saying, I think this, for me, the council part of this is wider than the people side. So I think I definitely see a place for place colleagues in this quite clearly. There's a lot of work going on across the different partners, including those other departments of the council around things like digital exclusion, anchor institutions, etc. And it'll be great to pull in some of those colleagues as well. I think that would really help us.
Okay, thanks. Judith.
And just picking up Oliver's comment on the chat, I think we're very happy to schedule that discussion, and that you can very much hear the enthusiasm for that. So that will be part of this work, and then we'll bring that back. And happy to involve any interested members of from Oliver's team if that would be helpful.
Yeah, Oliver, did.
Thank you very much. Yes. There's so many different issues, aren't there? But it's a really useful report. The problem is, I mean, it's inequalities has been highlighted quite recently over the last couple of years, which is great. At least it's an awareness. But dealing with it is not so easy, particularly as there's so many other different pressures going on. So just as an example, which people may have their opinions on, there are services being centralised by the trust, moved away from Ealing to Northwick Park by leading clinicians, looking at how they can most efficiently deliver services, but they're not necessarily in a position to look at detailed impact on local communities, and that. If you look at the move towards centralisation, move towards the ICSs, that's one of the risks, that as you centralise, there's advantages and there's also some disadvantages. And if I can just read you a couple of sentences from the Ealing Council response to the consultation on Case for Change about 18 months ago, which was the precursor to this centralisation. And the council response included, it's vital that there's a continued recognition of the variations in communities across the sub-region. You will be aware that Ealing is the largest authority in the sub-region and has a very diverse community with significant levels of deprivation in a number of wards. And with this comes a host of health inequalities. And then it goes on to say, we strongly hold the view that local population health improvement needs to have a local focus, and the proposals will not support effective responses to the different needs of the communities in North West London. So, I mean, that's come and gone, that consultation, obviously, but nevertheless, I think Ealing Council and other councils who said similar things did put their finger on a problem. And I think it would be quite useful to discuss that I mean, there's parallel discussions about the role of the private sector in taking decisions and all of that. I mean, it does throw. It seems to me it's only local authorities who are able to examine some of the detail of inequalities. So it would be great if that could be discussed in relation to the ongoing reorganisation of the ICS. Thank you.
You've prompted a flurry of hands. Judith, was it coming back? I know you'd mentioned this in terms of having come up in the chat. Did you want to come back on that first? And
yeah, yes, absolutely. We're very happy to have that conversation in the way that we've outlined. Just in terms of the context of that letter that was written without the awareness of the developing integrated care partnership and the strength that we can see building in terms of our borough-based health and place arrangements. So we can see that there will always be a rub between the centralised model and the local model. But I'm pleased to say I can see that we're growing in strength in the local context and very much able to think about our synergies together, whilst there being also some benefits of health provision, for example, in acute hospitals wouldn't be done locally, they're better done across the eight. So we can see the logic of it, but where we see the tension and any concerns for our local residents, we'll champion them, and so will our local health partners. So I'm more confident than I think we were at the time of the writing that letter. Nonetheless, we'll continue to campaign on the levelling up agenda to make sure our residents go upwards wherever possible, and that there's not a levelling down ever in terms of any adjustment across North West London in terms of equity. Thank you.
Yeah, and I think the renewed focus of the health and wellbeing strategy on inequalities, and I know it's an ICS priority as well. And as we move on to the Race Equality Commission agenda items shortly, the data that comes out of it will certainly be monitoring and looking at outcomes and seeing actually what is the impact of reorganisation of service changes, and making sure that whether it's this body, whether it's the council as a whole, whether it's the health scrutiny panel, we are holding the right people accountable for outcomes and whatever those outcomes may be and whatever impacts service changes, reorganisations may have. Vijay and then Chris, and then I'm aware we're getting to 7:20 already. So Vijay, if you want to come in.
Yeah, thanks a lot. I'm just picking up, Oliver, in terms of the question in the chat and what you've mentioned earlier on. In terms of the NHS organisation, yes, we are moving from a single CCG with that commissioner provider split to an ICB integrated care board with a complete partnership amongst all the providers across North West London. So really, what that demonstrates, it demonstrates that the partnership of health providers are coming together, and that also will include councils and local authorities at that top table. So our ICB board will also have representation from council in terms of the decision making that is made at an ICB level. In terms of health inequalities, it is one of the main priorities for the ICB going forward in terms of how we tackle health inequalities, which we all know is very complex and very multifactorial, and at a borough level is where the actual doing is going to happen. So the ICP will have a key role. Our local ICP will have a key role in tackling health inequalities at a local level, and every ICP across North West London will have that as part of their remit and their priority to ensure that we do look and tackle health inequalities, which will be no doubt different for each borough in terms of their in terms of social deprivation, health economics, and health deprivation. So I can certainly try to assure you, Oliver, that it is definitely in the forefront of the ICB in North West London going forward in terms of how we do this.
Sorry,
Oliver.
Yeah, I mean, we have had a lot of discussions.
Oliver, I've got Chris waiting.
Okay.
And so if you don't mind, just we take Chris first. Thanks.
No problem. I'll try to be brief because I'm in danger of agreeing entirely with colleagues. But I wanted to just say two things. One as a partner within the North West London integrated care system, I think it is fair to say that most of the work that we're doing has been focused on trying to reduce inequalities across the region. So there's a lot of discussion around levelling up for services and making sure that any resident of North West London has access to the minimum level of services that are wanted. So just to acknowledge that there is a dedicated work stream led by the Chief Executive of West London Trust into population health and inequalities, which has a loud voice within the integrated care system. But also to agree with the points that you've implied, Oliver and Judith and BJ have made. As the ICP director for the place-based partnership, I think that's a really, really important role that I have with colleagues in the leadership team locally to make sure that place is really strongly heard and that the needs of Ealing are absolutely recognised in those discussions. So would really welcome further conversations to share with you the approaches that we're taking on that and to bring back further items to this group and to be held to account by this group and the scrutiny committee for the work that we're doing locally.
Thanks. So I think we're starting to have a conversation that's kind of goes on to the next agenda item. I'm conscious that it's already 7:25, and I think there's appetite certainly to talk about ICP and ICS and how those are, what they're doing, how it impacts the work of this board and the accountability of those structures. And I think Judith popped in chat that we can bring a substantive item back next time. So I think if we do that conversation now, we're in danger of having less of a conversation about a very important item next. And also we do need to cover the pharmaceutical needs assessment as part of the preparation for the health and wellbeing strategy. And I do want to hear from Simon on Northwest London.
I'll just say that the devil's in the detail, of course, isn't it? But okay.
Yeah, let's have that conversation, but let's have it properly next time, so we can dedicate proper time to it. So I think there's general consensus around the approach. So Anna, I think we've got kind of green light for your team to start work on that, which is very exciting. So thank you. So we move on to the Race Equality Commission recommendations. And before I ask Anna, Joanna to do that, Peter, do you want to just set out some of the context behind the Race Equality Commission and the Council's overall approach to the recommendations, and then Aisha as well as the portfolio holder?
Yeah, thanks, Josh. Look, I don't want to take up too much time sort of being conscious of our need to get this over by sort of 8, but equally, it feels a bit odd, doesn't it, speaking at a health and wellbeing board in front of people for whom sort of health inequality sort of is the driving mission, to sort of be having a conversation about the impact of health inequality on race. These are, in many ways, topics that we have known about for an incredibly long time, ones that sort of do form the central part of health and wellbeing assessment, as well as the work that is being done. Nevertheless, of course, the events of the last few years have sort of shone a spotlight on this in such an incredible way. And I'm sure many of you have sort of heard me talk, perhaps in less formal settings, about some of the health inequality that we know exists between places like Norwood Green and Northfields, and some of the the compound elements of race and inequality that sort of map onto so many of those differences. I think the key thing that I would probably say in terms of you being familiar with the fact that we undertook a Race Equality Commission that was independent of the council but supported by it, chaired by Simon Woolley, was that it was entirely that which was an independent view of where we are, that came up with some sort of quite challenging demands that the officers are going to take you through. I suppose the bit that I want to underline is the administration and the council's commitment to making sure that this isn't just a one-off, that it's not a report that sits on a shelf that goes away, and therefore what we've agreed as an authority is we actually agreed at our sort of last full council meeting, where we even wrote it into the council's constitution to sort of protect it, certainly against anything by way of 2/3 decision making, but is to institute what we're calling a sort of citizens tribunal, borrowing the language, yes, very explicitly, of justice, to be able to ensure that in a year's time, an independent body of the council, again supported by the council, has the ability, if you like, to put us on trial, to check whether or not, according to its own metric, that we've done enough, to meet the demands, and that we can evidence that very clearly in terms of our action to sort of close those gaps. So I'll hand over to Aisha, who potentially might want to focus in on a few bits and pieces. But that's certainly the approach that we are taking now. Part of the new mantra of open, inclusive, and transparent is actually sometimes you do have to let go. You do have to let go of some of your control in certain areas to people, to sort of hand power back to them and allow them to sort of take the lead. But I'm sure if we engage as the council and as public sector partners in the spirit of openness and transparency with the Citizens Tribunal, as I'm sure many of you did in the course of the Race Equality Commission's work itself, that will itself beget a better relationship with residents and with people advocating on residents' behalf, to really move the dial away from paternalistic, patrician and patriarchal relationships within local government and within public services to a more mature, open, adult relationship with people, in which we have the ability to talk about very difficult topics and take with us on a journey that we know that it's not that we need to go on, it's that we have to go on. So yeah, with that, Aisha.
Hi, yeah, so basically what Peter said, I'd like to pretty much ally myself with what the points is that he's made, but I'd just like to add a bit about the engagement part that we spoke about in, I think, a couple of the reports that we've just had, and the one that we're just about to talk about is going to be a really important bit to actually engage with all those different bits of our very diverse borough, and to listen to where we're failing and where we can fix things and be a bit better about. And I think going forward, that was the same for us at the council, the same with our NHS partners and across the piece, is that listening to all of those communities and reacting to them is going to be the main sort of job, I guess, of this year. My job as the cabinet portfolio holder for tackling inequalities is basically to make sure that we deliver and implement on these recommendations from the report from the Commission, because quite a lot of these things, as Peter said, are quite uncomfortable and are going to be uncomfortable going forward for us and for our partners. But the listening bit is the bit that I think we really do need to, the engagement, the listening is going to be absolutely key. So with that, I will hand over to Anna, who will take us through the report, I guess. Thanks.
Before we do, just looking at the slides that are about to come up, where you see the word recommendations, please substitute the word demands, because the Commission didn't make recommendations. They didn't say these things you ought to do. They are demands from the lived experience of our residents, say the things that we must do. And as Peter says, as Aisha says, we've accepted them, we know we must do them. So please, for recommendations, please read demands. But with that said, Anna.
Thank you, Chair. Thanks, Councillor. So I'm going to introduce and finish this off, and then I'll bring in Joanna Sumner, who's our Council's Assistant Director for Communities and has been leading this work within the Council. Is just going to give some of the oversight in the middle and be here to help answer questions as well. Thanks, Jack. So I just wanted to run through just a couple of things we've touched on under other slides, just because of the way the agendas have come together. So next one, please, Jack, if you can move on. Thank you. So just really wanted to just do a bit of a reminder, I suppose, for how diverse Ealing Borough is. I lived in Ealing for about 15 years and didn't quite understand how diverse it was until starting this job. third most diverse borough in England and Wales. Obviously, some of the big populations in terms of Polish, Japanese, etc. And you see the list there. So, and when you look at that in terms of community languages as well, you can really see it there as well. Next one, please. And I think one thing that always strikes me when you're talking about ethnic minorities, actually, you know, the white group is counts for less than 50% of the population. And when you look at the projections going forward with how the population's changing over the next few years, the other ethnic groups, especially Asian and Black ethnic groups, are rising faster, especially among those younger age groups. If we can skip the next one, Jack, please, and move on to the one after. Thank you. We've already talked about COVID, so I won't go into details here, but just some really stark statistics here. I think this is nationally. We were seeing Black men and women and Asian, and particularly Black Caribbean in this, more than twice as likely to die from COVID than white men and women within 20 and 21. So, you know, you are seeing absolutely huge differences, and there are so many factors behind that. And you can also see the flip side of that with our vaccination uptake, for multiple reasons in here, where we've got much lower vaccine uptake in some parts of our population, particularly Black and mixed Black ethnic groups, particularly Black Caribbean, and also traveller Arab groups as well. Won't go into the details here on the kind of whys behind that, but they are really, really different statistics showing there. So if we just move on, I think I'm handing over then to Joanna. Thanks. Over to Joanna. Thank you.
Thanks. I think a lot of this kind of first slide about the kind of background and what we were doing has also already been covered by Councillor Mason and Councillor Vaza, so I won't kind of go through that at all really, but I suppose just to say that we are kind of now recruiting kind of people to this kind of citizens tribunal so we can get on with the work kind of immediately, which is about kind of holding to account, but also kind of working with people to develop the proposals about what's going to work to kind of make some fundamental change here. Yeah, I think I'll just, if I move on to the next one. So it was worth running through what's demanded for the priority areas, and it's also worth saying I think there's lots of common ground across these different priorities. Lots that came up in our work about how people felt treated by public services, which I think Councillor Blacker you were referring to earlier. When they try to get help with housing, when they kind of encounter the police, when using health services too, people feel that's told us that they didn't feel treated with respect, and that they didn't trust these public services to have their best interest at heart. There's a big strand throughout about kind of representation, kind of senior teachers, GPs, elected councillors, senior managers in local government. They all need to be more reflective of the kind of variety of different communities in Ealing, and that really matters to people. People did talk about that a lot. The wording in the education priority that I've put in here, that demand that really struck a chord with people. Our children are not underachieving, they're being underserved. Black children in Ealing do considerably less well at school than their peers, even when you take other factors into account, such as levels of deprivation. And so turning that around so it's not expressed as something that children haven't done, has been accepted by people working in schools as a really useful way for them to reframe and refocus what they're doing. So 7 priorities are set out there. I won't go through them all, kind of very, very summarised there. And number 7 is about keeping the pressure on so that commissioners don't look back at this work in a few years' time and feel that very little has changed. And that's the big fear for people that I've spoken to in community organisations. Why should it be different this time is what people say when they're being kind of reflecting on you know, this looks good, but why would it be different this time than it has been previously? So that's me, I think. Over back to Anna for the next slide.
Thank you, Joanna. This is really what we wanted to bring here. I think a lot of those themes that Joanna's mentioned are really important. We can obviously run through each of the health demands in here, but actually those cross-cutting themes that came out, especially around trust and representation, I think are really key when we're working on these. But the crux of the reason for this agenda item is really to bring these health demands up to the Health and Wellbeing Board, essentially for ownership, and to have a discussion together about how, when, who takes these forward. Obviously, there'll be a lot of detailed planning outside of the board meetings, but really just about a commitment here and a bit of a discussion about priorities within these and what resources we need to contribute to these. So just really wanted to just run through the 5 here. First one was around our clinical commissioning group as commissioners to draw up a strategic plan about greater representation of communities. This was particularly about health service providers, for example, GPs, but also leadership positions, and particularly seeing that there's a large representation from, say, South Asian communities, but less so from Black African, Black Caribbean communities. You know, where can we make those opportunities and those changes? One about learning lessons of the pandemic, particularly in terms of inequalities, and I'll go on to that in detail in a minute because that work is starting. All the council care health agencies reviewing priorities for Black and Asian minority ethnic communities who've been disproportionately left behind. So really looking at all of our key plans and priorities with that inequalities focus, particularly in terms of Black African, Black Caribbean communities, was particularly raised. And alongside that, really deeply reviewing the data on health outcomes, particularly by ethnicity, and working out where it's even not collected and where we need to do more work on that, so that we are always looking at our services through that lens of inequalities, particularly in terms of race. And then the last one, a demand there about exploring primary care funding and resources and redirecting that to the most diverse parts of the borough, rather than just as a universal statistic, I suppose. So I just wanted to delve into, on the next slide, Jack, thank you, about the lessons learned from the pandemic. This is work we're just starting that my team's leading on behalf of the board, but just wanted to bring it here because it's very early days and just wanted to get a steer on whether this feels right. So this for us is kind of what's worked, what hasn't worked with our response for COVID across the partners. And particularly in terms of that inequalities focus, you know, and it's not necessarily for another kind of communicable disease outbreak even, it's just, you know, good learning for how we work together across a number of topics going forward. So there'll be some work in terms of looking at the lessons already learned from different areas, like when we did, say, surge testing, for example, what services have been provided, feedback from service users, working with each who are leading a consortium in terms of some of our community groups to get feedback that way, and also leaving in the Vaccine Champions programme. And I think also importantly for me is actually reviewing across our partners how we work together as partners, what worked well, what didn't, what can we learn going forward, how have those relationships strengthened. I think that's a really key one for me. So next slide, please. Thank you. Just very briefly, this is essentially work we're planning to do over the next 2-3 months. So really over March, April, May, doing all that work, writing it up, hopefully being able to produce something by the summer. Next slide, please. And then just finally, I just wanted to say, obviously this work isn't happening in a vacuum. There's lots of different strategic opportunities here where this work can be taken forward. So we've already talked about health and wellbeing strategy. We've already talked about the joint strategic needs assessment, those principles for system-wide working we talked about. Whenever we're reviewing any of our local organisation policies and practice, especially around things like workforce development and recruitment, a lot of the integrated care work especially. So for example, I chair one of the integrated care partnership subgroups on population health and inequalities. So obviously that's a key stream in here. And we've got pilot projects happening about how we work with our very local communities together across our partners to reduce those inequalities. So I think that's the last slide, Jack, can you just check for me? Yes, thank you. So that's all from us, but obviously Joanna and I and everybody else very happy to be part of that discussion about how the Health and Wellbeing Board takes ownership of this. Thank you, Chair.
Great, thanks, Hannah. And we should probably thank, although they have all been thanked before, Lord Woolley and all the commissioners for the work that's gone into this, and indeed all the residents who fed in as well. So they're not necessarily comfortable truths, but they are truths in terms of what was found. So Simon, I think you've unmuted to respond.
Yes, so thanks for the Judith. In terms of the lessons learned and the bits you're looking at, the only other question I had was are you going to be looking at outbreaks and cross I want to say contamination, but I don't mean cross infection as well, because it's certainly something within the hospital as part of our learning lessons is looking at how we contained it and how we contain patients and any sort of cross infection issue. So I was just wondering if you look at that in the context of A, communities, B, care homes, and maybe schools as well.
Yeah, thank you, Simon. I think that'd be a good idea. I think there are different settings that will look at different aspects, but I think they'll all provide something useful going forward that isn't specific to COVID. So yeah, we could definitely weave that in and work out how we do that. Thanks.
Great. Other thoughts, contributions? I know, Vijay, there's a big challenge in there for the CCG. So I don't know if you want to ruminate on that for a minute while Fabio makes his contribution. Fabio.
Thanks. It was just really on the community engagement element of it and looking at how, in terms of the strategy, in terms of reaching the people probably who are the most, maybe isolated's not the wrong word, but most distant from the systems, to really see about what those barriers are and what the strategy that's in place in terms of how those people are going to be reached and the conversations that, how they're going to happen. And also in terms of the recruitment for the panel, the tribunal, I'm not sure what you want to call it, that's going to hold the council to account on it, in terms of how are people going to be recruited for that, to make sure that it's, you're getting sort of the right sort of, variety of people on that panel.
Peter, do you want to pick up on the recruitment to the tribunal? And then Anna, you can pick up on engaging with different groups.
Yeah, I think it's worth actually, if Joanna is still with us. Yeah, you are. I can see on my screen, Joanna, sort of talking us through the recruitment process. I think the key is the speed at which we do it. So Joanna, do you want to maybe speak to it? Yeah.
So I think we're going to be able to launch something fairly soon. And the idea is that it will be an open process and we will advertise it kind of widely. It's not a job, but we want to make sure that as many people as possible have the opportunity to apply. We will, I think, and obviously we will identify people who we think, might be good, because I think one of the things we want to do is bring in kind of people with expertise, so that, because we know we've got the areas identified. So certainly for health, we'd want to look, if people have got ideas about who you think would be good on this, please do let us know. But there will certainly be an open call for people to apply. I can't give the precise dates now because I'm just kind of finalising that in the next few days, but we will certainly advertise it widely, and there'll be a process where a kind of independent panel make decisions on who gets selected, which will be led by kind of colleagues in kind of ECN and the community network, so that their kind of independence is definitely maintained.
Thanks, Joanna. Anna, do you want to come back then on how we engage with different
I was
groups?
actually going to volunteer Joanna as well, if that's okay, just in terms of that community engagement question.
I mean, I think one of the things that worked well with the commission is where we went out to groups and we spoke to people. So we had kind of groups like GHOST had work with some of the people that they work with and support, and kind of talk to them about their everyday experiences of services and so on. And that kind of, I think we can kind of amplify and extend that approach to the work, kind of going where people are and not expecting people to come to us, and having different conversations about specifics, and being really clear about what so I think one of the things I'm hoping that the tribunal does is kind of works up proposals with people, so a kind of co-production, kind of collaborative way of doing things, and so we can kind of go to groups and work with them on what they think would work and test things out, and kind of come back with better proposals.
Thanks, Joanna. Any other thoughts, comments from people? It's a big ask for us. Vijay.
Yeah, just in terms of the report and the recommendations for health, just picking on a couple of points. One is around in terms of the health professional community in Ealing and the level of diversity. So as people know, we do have a diverse health professional community in Ealing. I do suspect that the proportion of Black and Afro-Caribbean health professionals in Ealing it's probably lower than other ethnicity groups, and certainly there is a lack of that particular group in sort of senior professional roles in terms of clinical decision making, which certainly we can start to look at and explore. The other area around primary care funding and trying to focus the funding where the needs are the greatest. There are some difficulties and challenges around that because majority of primary care funding is determined nationally, and it uses the Cahill formula, which isn't perfect in terms of how that formula is used, looking at age and deprivation and ethnicity in some of its parameters, but it doesn't really give you that individualized, bespoke way of focusing the resource to where the needs are. And local funding that we use for primary care, we currently don't have a sophisticated formula to able to focus that funding, and we have to focus the funding across every practice in Ealing, and demonstrate a level of equality when we do that. So it is something for us to consider how we can try and use a more bespoke approach going forward. But it's not going to be easy, but it's certainly something that we do need to consider going forward. But I think what COVID has done in terms of health inequalities, particularly for certain ethnicity groups, it's shown the health vulnerability of particular cohorts of our population, and we've known for a long time that certain groups in our population have a disproportionate level of disease burden. So you look at chronic kidney disease and dialysis. We know that the population of certain cohorts, particularly Black and Afro-Caribbean, are much higher when it comes to chronic kidney disease and dialysis as another example. And the prevalence of strokes in Black and Afro-Caribbeans is higher than in the white population, partly due to their genetic makeup in terms of medication-resistant hypertension, and then leading to consequences of that. So there is more work to be done, and we are as a system trying to address that. But I think locally we do have individual challenges, and we do have areas, particularly in Southall and Acton, particularly in terms of how we tackle the health inequalities and raise the health profile for those certain populations. And we have done some good work reaching out to these groups, particularly in terms of a COVID vaccination uptake. But we need to now use those lessons learned and try and translate that to other areas of health inequalities as well.
Great, thanks, Vijay. This is a topic we will come back to, particularly given the endorsement of the approach to the health and wellbeing strategy around health inequalities. It's not something that we're going to, as Peter says, put on a shelf and carry on with our lives as normal. So we will return to this conversation as we move through, particularly the lessons learned will come back. And, you know, if there are aspects of it that challenge your organizations, we can help have conversations with you about how we can support you in making changes that are needed, as well as kind of asking you to help us focus on some of the wider issues through the health and wellbeing strategy. Thank you. Simon, are you able to give us a very brief 3-minute update covering the gamut of services and issues in the last 3 months?
So in the interest of time, so Joe was going to share the screen, but Joe, if you just go to slide 3, and I'll just pick a couple of these slides out, so I won't spend too long on them, if you like. So the first one is some 3 key leadership changes within the trust. The first is that Pippa Nightingale is appointed as the new chief executive. She commenced with the trust on the 14th of February. I suspect she's well known to many of you because she was previously the chief nurse at Chelsea Westminster and also led the vaccination program across Northwest London over the last 2 years or so. So she should be well known. She's hit the ground running, clearly an experienced executive, nurse by background, and has certainly gone down very well within the organisation. And we're also delighted then that James Walters, who again many of you will know because he's been with the trust 10 years plus as a divisional general manager deputy, he was appointed as the chief operating officer and commenced his role on the 14th of March. And Matthew Swindles has been appointed as the joint chair of Northwest London Acute Provider. So, and he will commence in that role from 1st of April, covering our trust, which is London Northwest University Hospitals, Chelsea Westminster Hospitals, the Hillingdon Hospitals, and Imperial College Healthcare. So previously London Northwest and Hillingdon, we've shared a chair for the last 2 years. Sir Amos Morse, he steps down at the 31st of March, and Matthew takes over across the 4 trusts. Matthew was previously NHS England's National Director of Operations. Just the next slide then, Joe. So COVID bed occupancy, this has been going in the right direction as indicated there. What I would say in the last 2 weeks or so, we have seen the numbers going up, certainly at Northwick Park more significantly, but at Ealing as well. That a lot of the patients are admitted incidentally with COVID, as you can see, 6% on that screen. So they'll come in with other, especially in the frailty population, they'll come in with other conditions, but as a consequence of being frail are also vulnerable to COVID. So they're coming in for other reasons. So we are watching that. At Ealing, I think this morning we had 16 COVID positive patients, and at Northwick we had 67. So that's not going the right direction, but we're hoping it's like the evidence elsewhere. We're hoping that it's a small peak and will peter off over the next 2 or 3 weeks. Recovery headlines. I did mention some of these earlier, so I won't repeat them. We will circulate the slides, so I won't go through that. But just to say that we are making good progress. We are comparing well nationally in terms of our recovery. This slide now to the service developments. Just want to highlight that during the COVID response, we increased critical care capacity on the Ealing site to 12 beds. And those are appropriately staffed as well. We reinstated emergency surgery on the Ealing site from the 30th of December, and that's working appropriately. We had unannounced CQC inspection of our medical wards, in particular at Ealing, in February, and those indicated significant improvements from last time. We haven't received the formal report, but we're hopeful that it's really positive. And just to say that on 28th of March, trauma services, overnight services will also recommence on the Ealing site. The refurbishment of the endoscopy suite will complete at the end of March. MRI replacement due for completion end of June. Procurement of a new cath lab is underway and expect to be complete in September. And as a trust, we are working with Hillingdon Hospitals. We've procured Cerner as our new digital electronic patient record. And it's the same platform that both Chell West and Imperial use as well. So all 4 acute hospitals will be on the same platform. We go live August 23, Hillingdon will go live November 23. So then all 4 acute trusts will be on the same platform that will significantly help sharing of patient information and seamless care for patients in Northwest London. Operating plan, fairly techy. I won't go through the detail of that, but what's in there is the expectation of the national ambition and plans, and you can see where the current trust plan is at that. At the moment, the stretch target for elective surgery, day cases, inpatients, etc., is 110%. We're planning to deliver 104% in the early part of the year, rising to on average 106% by the year end. Our targets for outpatients is 107%. This is 107% of what we were doing pre-COVID. It's the same for all of these. And you can see the same for MRI and the diagnostic targets that we're looking to achieve, and reduce the number of long waiters as well. So we'll have no one waiting over 72 weeks by the end of March. Nobody waiting over 104 weeks by the end of June. And 52-week waiters halving during the year. And then the last slide, then I highlighted earlier, we're looking to, as a trust, redevelop our strategy. The last one was 2018 to 23. It had been produced while SAF was still alive. And so it's really timely with all the changes that's happened across Northwest London and in health over the last few years. It's really timely for us to embark on a refresh of our strategy. And we'll be doing that across the 3 boroughs, and we'll be looking to engage with patients, community groups, and obviously our partners in Ealing in terms of looking how we take forward a strategy for Ealing Hospital and a vision for that longer term. So I think part of the plea post SAF has been, what is the site strategy for Ealing? So this will really help us answer that question. And as part of that, we're clearly looking at how do we make the best use of that site to maximise the potential of Ealing Hospital for Ealing local residents. So whistle stop tour, but happy to take any questions. And yes, we will share the slides.
Great, thanks, Simon. Any burning questions for Simon? No? Fantastic, thank you. So the only thing we need to do, there is a paper on the pharmaceutical needs assessment, and I won't ask you to talk through it given time. There is a project plan and terms of reference that we need to note, and we need to agree if the board are content to delegate sign off of the draft and final pharmaceutical needs assessments to Anna and the P&A steering group. Is everyone happy to do that? There are nods, which is excellent. Thank you very much. If that hadn't happened, I don't know what we would do, given it needs to be done. So thank you very much. It is 1 minute to 8. I think there's one question from Roy that's been picked up in the chat around equity and access to social care. Judith.
Yeah, we'll pick up Roy's question, so that'll absolutely be built into our risk quality response. So thank you for that, Roy. I was going to come in as in any other business, Josh, when you're ready. Thank you.
Yeah, that's absolutely fine. I think I was about just getting there. So Judith.
Yeah, thank you. So we should just acknowledge that Mahini Palmer, who was Dr. Mahini Palmer, who was deputy of this board for a number of years and chair of the CCG and a lead player in Northwest London, is retiring at the end of this month, and she'll be a great loss to the health and social care system. She championed integration and had much strength to bring to our partnership working. So I just wanted to acknowledge that. Certainly on behalf of the council, there'll be other opportunities to say it, but I wanted to express our appreciation from the council.
Great, thank you, Judith. There are claps and thumbs up from across the board. So our appreciation for her work in Ealing is noted. With that, then, unless there's any other absolutely urgent other business, I think at 8 o'clock we can draw the meeting to a close. The next meeting is on the 8th of June. I will note it is after the local election, so I hope to see you here. but that's not in my hands. But I hope to see you on the 8th of June.
Thank you. Have a good
Thanks,
evening.
everyone. Good night.
Bye.
Thanks, everyone.